All right, so for you guys on the Zoom link, in the announcement that had the Zoom for this morning, there should be a couple replies. In those replies are the handouts that I've given to everybody, except for the KWL. You can just write those on a sheet of paper, K, what you know, and then later on you can fill out the W and L portion. All right, once you've filled out the K, let's go ahead and join the Menti. You can do it either through going to menti.com and entering the code or scan the QR. Either way, it'll go to the same place. I don't care if you do it on your phones or your computer, either way. Good morning. I have a few papers in the back. Make sure just to grab one of each. There are just 3, not the plus delta. I think that's left over from Sim. Oh, come on. So I'm kind of excited about today. I think some of you guys know right now, I currently have another gig other than teaching. I work in recovery or in perioperative at St. Clair Hospital. I've been there, oh, there's lots of fun stuff. I worked there at St. Clair for over 15 years. And so right now I still work what's called per diem or as needed from time to time at St. Clair. So this weekend, I actually had a call shift and I got called in a few times for patients that needed emergent surgery. So I thought, gosh, this is kind of appropriate, right? That I was able to go in, and as I was taking care of some of these patients, I was like, gosh, I wish I could take all you guys in my pocket and just like carry you around with me, like as I was caring for these patients, because I think there's so much that is you can gain from actually seeing it and watch somebody go through that. So on my way out, I grabbed a copy of one of these report sheets that we use. So as we go through this lecture today and talking about pre and post-op care, we're going to kind of fill this out, kind of pretending like we're caring for somebody, right? This is, and it kind of looks like there's a lot going on here, right? I'm just going to go over it a little bit with you guys. The very top, has a patient label. We're always going to put a name on it. Now, all of this stuff is in a computer as well, right? Like my facility uses Epic or an online system. But most places, they're going to have some sort of paper thing that's going to follow the patient. So it's a quick, easy access to use as well. And this gives you a good idea of what kind of things we monitor or the things that the nursing staff is responsible for. Morning, guys. Go ahead and grab some of the papers in the back. So you can see there's 3 different columns here. And this is about the 3 different areas of surgical care that nurses are involved with. So this first one is pre-op care, or what does it say up here? SS, admit, and all this other stuff. That's when you're getting somebody ready for surgery. The middle portion is when somebody is in surgery. And then the far right portion, that's recovery or when they're done, like after surgery. So as we move through these things, this report sheet kind of highlights some of the things that are most important to take care of or to assess or determine when we're looking at these patients. So if you have joined the Menti, please go ahead and give me a thumbs up, a like, something, because we're going to start moving through. Anybody new have any objections to me recording the video today for the lecture? No? Okay. All right, so, oh yeah, I always forget to turn this guy on. We're in chapter 12. Good morning. Grab some of the papers in the back. We're just getting started. So we want to talk about a few things today. There's a bunch of factors that can affect patients' outcomes, how they do after surgery. We're going to talk about what is our role in taking care of these patients. We're going to explain informed consent. That's a big deal. We're going to talk more about that in a little bit. We're going to talk about a teaching plan. We're going to talk about what intervention that we're going to begin to help prevent some of these complications patients can have after surgery. We're going to talk about signs and symptoms of those post-op complications, criteria for ambulatory discharge. What is ambulatory? Walking out, right? Yeah. It's a different ambulatory discharge rather than you're discharging to maybe another facility or a rehab center or something like that. We're also going to talk, actually we're not, I took that out. We're not going to talk about home health care and post-operative. So surgery urgency levels. So an emergency surgery is where somebody's probably going to experience loss of life or limb. If they don't have surgery, usually within they need it right now. So one example of this was this weekend, I was taking, I'd already been called in, and I'll tell you more about that. But the second time I got called in, it was for a young woman who was relatively healthy, but she had a pregnancy that had miscarried, and she had had a medication to help her expel, or kind of remove the rest of, the pregnancy that had failed. And that caused a lot of bleeding. In fact, she was what we would say maybe bleeding out. And so for her, this was an emergency that we needed to get her into surgery so that the doctor could go in and stop that bleeding. Otherwise, she could die from bleeding too much. So that was an emergency surgery. Urgent is something that needs to happen within 24 hours. There's something that's really wrong, but it's not like we have to go right now. So an example of that might be one of the patients I took care of earlier in the day yesterday had fallen and broken his hip. It was such a perfect example. This is what I really was thinking about all of you guys, because his legs, he'd kind of broken his hip kind of high up on the femur, and his leg, it was the left leg, was actually shorter than the other ones. Oh, remember how we talked about that with some of the skeletal issues? Yeah. And then when he came out of surgery, after they had fixed the hip, they had done a ORIF. Anybody remember what ORIF means? Be brave. It's okay to be wrong. Open
reduction,
internal fixation. Yeah. So they had to make an incision. They had to straighten everything out, and then they did an internal fixation. So rods and screws, all that stayed inside, nothing was outside. When he came out of surgery, and I got him into the recovery room, you do all the things, making sure he's breathing right, blood pressure is good. And then I go and I want to look at his surgical site, and then I looked at his legs, and they were the same length again. And it was so fun to see that. I know it's kind of weird and gross, we had a short leg, but then they fixed it, and it's they're the same way, which is what we hope, right? We want to fix their problem and get them back to that functioning level. So that would be an example of an urgent surgery, right? Not something that has to be done right at the second. He was in a lot of pain. He was experiencing that bone scraping where it had fractured, scraping against each other. That was really painful. We didn't want to delay too long, but it wasn't that emergency, like he was possibly going to die within hours if we didn't get that taken care of. Elective surgeries. So we talked about our guy that fell and broke his hip. The elective surgery might be somebody who has arthritis in their hip, and it's really bothering them, but they can still function. They can have an elective hip replacement and get that, the joint fixed. There's a variety of other surgeries, but that's a good example. And then optional surgeries are things that usually are for cosmetic, or they're not really necessary. A lot of times we think about maybe breast implants, or people who get their nose a rhinoplasty, not for medical purposes, but because they want to fix the shape of their nose. That's an optional surgery. There's really not a medical need for that. Now, I do want to say that is different if you have a breast implant to augment somebody's breast size. That's different than somebody who had breast cancer and we are reconstructing that tissue, right? That's a breast reconstruction after cancer. That's a different thing. That's not really, it's still considered part of that medical plan, not necessarily optional. Okay, so the purposes. Oh, this is where we're talking more about that. So they might be aesthetic, right? We might have something like we want to change the shape of our nose. Diagnostic, those surgeries are when you need to go in and maybe somebody has a tumor or something that we want to go take biopsies from, or we want to say, yes, this kind of confirms this. There might be exploratory. Sometimes, a lot of times I think about patients with abdominal pain and they come in and we've done like a CT scan and we looked at the cavity and it's not really clear what's going on, but clearly something is very wrong with this person. So sometimes they'll go in and do what's called an exploratory surgery, which really is kind of what it sounds like, where they will, they usually start laparoscopic, and we'll talk about that in a minute, but they'll start with very small incisions and just look and try to see what's going on, see if we can fix that problem. There are preventative surgeries, and there are curative surgeries. So curative, I like to think about maybe an appendectomy, right? Somebody has their appendix is inflamed. We're going to go in there and take that out. We might even be removing a tumor or something if somebody has a cancer. Curative versus palliative. I had another patient who, this was not this weekend, but she had a very large bladder tumor. They had done chemo and radiation and other things, but that tumor kept obstructing things where she couldn't pee like she needed to. So they went in and did a surgery where they went inside the bladder and they just scraped a lot of that tumor tissue away. Now they weren't able to completely remove the tumor, but they were able to scrape away enough of that tumor to try to keep everything open and working. It wasn't that they thought they would be able to fix all of the issue, but they wanted to make her quality of life a little bit better. So the types of surgery, this is really important to know. And so we like to say like minimally invasive versus an open surgery. An open incision, and that's where we think about like maybe what's that game, Operation? Yeah. Anybody play that before? Yeah. And you have little buzzers. That is like the most stressful game when you're a kid. Because you know you're gonna get buzzed. But if you think about an open incision, that's where somebody has an abdominal surgery. They usually have a big line down the middle and they are opened up during surgery so that the surgeon can muck around and try to do whatever needs to be done. That's pretty invasive, right? Right. When I talk about infection from a few weeks ago, you have a big open area and we're doing a lot in there. There's a lot greater risk of infection as well as some post-op complications versus minimally invasive. A lot of procedures are going to start or at least attempt minimally invasive. Most consents, we're going to talk about consenting in a little bit, will usually say if they're going to be endoscopic or laparoscopic, they will say endoscopic or laparoscopic, possible open, maybe cholecystectomy if it's a gallbladder surgery, or appendectomy if they're taking the appendix out. Because the plan would be, we just want to do the minimally invasive, but if we get in there and this is more complicated than we think, then we want to say, okay, we want to do open. With the endoscopic and laparoscopic, it's really fun. There's just little holes that they put in. Usually they use the belly button because you already have, like your belly button's a scar, right? What is it a scar from? Your umbilical cord. Yeah, your umbilical cord. So they usually will do the larger instrument or the larger piece goes through your belly button. And then they use a couple other sites that will they also put instruments in. They blow up your belly with surgical gas. So your belly cavity looks kind of big. And then they use those tools to kind of go in minimally invasively so that your hands are in there, like maybe if it's your gallbladder. The surgeon's hands aren't inside of you taking out the gallbladder. They're using these instruments kind of through these little incisions they've made. Robotic, kind of similar, but they actually have robots that they use to go in and help with suturing, mapping. There's one at the facility I work with. It's really interesting. They have for their total hip replacements. You have a surgical side, maybe it's your left side, you're gonna get your surgery done, but you're gonna have a robot incision, which means that the robot, and it may make an incision, and the robot essentially goes out and maps out the good hip to kind of plan out what they're gonna do with the hip that needs to be replaced. So I know when those patients come out of surgery, I need to assess the incision at the surgery site, but I also need to assess the robot site. There was one patient a couple of years ago who came out and his blood pressure kept dropping and his heart rate kept coming up. And something was wrong with this patient. And we could not figure it out. It wasn't my patient, but I was there in the recovery room and I was kind of helping. We turned the patient and looked, because we looked at the surgery site. We're like, are they bleeding somewhere, right? Like usually when their blood pressure is dropping, their heart rate's going up, this doesn't look good. The incision looked great. Finally turned over and looked at the robot site. And there was a huge hematoma. And he had just been bleeding out from this robot site. Like why he had been bleeding out of that area, that's the only time I've seen it out of like hundreds and hundreds of surgeries doing that. I don't know. But you want to make sure that you're looking at all of the different places that anybody gets an incision at. We're assessing all of those. And then laser. Lasers are what sometimes we use instead of a scalpel. Right? A scalpel is like a sharp little knife used to make cuts. Sometimes they might use lasers instead of scalpels. I like to think sometimes like with lithotripsies or when somebody has a kidney stone, sometimes they'll use a laser or even shockwave to try to break up those kidney stones. There's lots of different tools that we use. It's so interesting, guys. I think this stuff is fascinating. It's like big science experiments. So you can see here, this is a type of robot surgery where, you know, they've made incisions and they have all these different robotic arms. And here's the surgeon over here, like he's playing on a video game. Isn't that crazy? Oh my God. That's a pretty intense form of it, but that is kind of what can happen. And you can see here, there's cameras that are inside. And so they're watching actually what they're doing inside. It's pretty interesting. $8 million.
Oh, can we have it here already in Washington, like the robotic like that?
What's that?
Do we have that here already?
Yeah, oh yeah. Yeah.
I've had that comes through.
Yeah, it's super interesting. And as we have medical advances, guess what, guys? They didn't really have this when I was in nursing school. That was 20 years ago. Think about what's going to be like when you guys, right? You're going to graduate this next year. In 20 years after you've been working, what are they going to have?
It's gonna be like Star Trek.
Right? Are you going to go through like a scanner and they just fix everything as you walk through? I don't know, but it's really interesting, all the advances that we make. So let's go back and let's think about our surgical patient who's coming in. So regardless if they're coming in for one of these emergency surgeries or one of these ones that are kind of emergent, or if we're just planning it out, there's some things that affect surgical outcomes. What does that mean? If I say surgical outcome, what is that? What do you think about? The results and how that patient feels, right? Did they recover well? Did they have complications? Some of the things, prehabilitation. So we want to plan out, these are big words, guys, sorry, it's still early. We want to plan out their preoperative, so that's before surgery. We want to plan out that function so we know that we can plan out for achieve the best outcome afterwards. So if we're planning a surgery, it's something that's elective, they're choosing to do, usually we have some time to say, okay, let's look at some of these things. What are some factors that maybe put you at a higher risk? And let's try to get some of those a little more controlled and get you a little more healthy so that you can have better outcomes. So some of these things that really can affect people are age, right? We know that as our bodies are younger, they tend to rebound better. We can compensate more. As we age, we compensate a lot less. You can go back. What was it, week 2? We talked about age changes. As we grow, our bodies just don't do as well as we age. Chronic diseases. You already have an existing condition, something that your body is already working on, especially if it's a respiratory condition or a cardiac condition. those things can really affect your ability to recover after surgery. Emotional responses. If we're really stressed about something, doesn't seem like that would be so huge, but our body has a big stress response internally. I'm sure you guys don't know anything about stress in your lives at all right now, right? Your body actually produces these chemicals. Oh, sorry, I'm probably moving my, sorry guys on the Zoom if I was blocking you. But your body will produce all of these things that act like these stress hormones that can over time have a negative effect on your body. Nutrition. If we don't have a good baseline nutrition, our body isn't going to be able to have all that it needs to either heal up the incision, heal up that new hip, do whatever it is. It needs a base of good nutrition. And smoking, alcohol, and drug abuse. Those are all really hard on our body, especially smoking, because we're going to talk more about surgery. We're going to essentially, most surgery, we are going to kind of knock out somebody's ability to breathe on their own, and we're going to take over for them. But in that can have a lot of respiratory complications. So if you have a history of smoking, you're already in your lungs. Even if you stop smoking that day, right, or maybe you don't smoke that morning, you're going to have longer lasting effects. Usually we say 24 hours, please don't smoke 24 hours before, or 4 weeks before. There's one of the surgeons that I work with that's very well known for his joint replacements, like hips and knees mostly. Every time that we get his patients ready for surgery, we do a nicotine test. We have them pee in a little cup and check for nicotine. And if they come back positive for nicotine, he will cancel the surgery because he knows that nicotine and smoking is going to interfere with how that joint heals. And these are elective surgeries, right? He's not going to do this on an emergency case that comes in. But he has told his patients, if you can't commit to stop smoking, for just this whatever window of time around the surgery, then you're not ready to have this done because you're not committed to this fully healing and doing well. Not all the surgeons do that, but I think that's really interesting that this guy is very research-based, and I can see where he's coming from, saying, if you want this to heal well, you need to stop smoking. Question or just hand up?
No, no question.
No worries. Okay, so first question. So sorry if your computer already went to sleep or whatnot. Which of these would the nurse state to describe the post-operative phase of surgery to the patient during pre-operative teaching? Okay, so test taking skills here, right? What is this question actually asking? Okay, so which did the nurse state to describe the post-operative phase? Okay, we're talking about post or pre, but it's during the pre-operative teaching. So the nurse is teaching the patient. What is she describing as the post-operative phase? Is it decision for surgery until transfer till PACU, admission to PACU for recovery, or provision of home health care?
I know, the question.
Yeah. What is post-operative phase? It's admission to PACU through recovery. So PACU stands for post anesthesia care unit. When somebody exits the operating room, they will go to a PACU or recovery room. And then once they're through with recovery, that's the post-operative phase of care or phase of surgery, excuse me. Oh, wrong one. Okay, so here's the 3 phases of surgery. And just like we have that little sheet, you didn't grab one, there's a couple of sheets on the back table. So preoperative, that's when they say decision of surgery. We'll talk a little bit about that until they transfer into surgery. Usually preoperative is talking about from when you come down into the pre-surgical area to get ready for surgery until you go to surgery. The intraoperative, that's when you are in surgery. You leave the pre-surgery, you go into surgery. And that's until you go into the PACU or recovery room. And then the post-operative is the PACU through recovery. So what is our role? So your role in the pre-operative phase assist with data collection. What does data collection mean?
The
Assessment. Yeah, it's your assessment that you're doing on the patient. You're going to reinforce teaching and instructions. And this is really important. I like to think about, have you guys learned incentive barometer use in fundamental or foundations? Okay. Incentive barometers. Almost 100% of our patients, we're going to tell them to use an incentive barometer. If we wait till after somebody's had surgery, when they've already had anesthesia, they're probably on pain medication, they're overwhelmed with all the instructions that they have, are they going to remember how to use their incentive barometer very well? Probably not. But if we, in the preoperative phase, as we're getting them ready, if we can give them an incentive barometer and teach them and have them show us a couple times, they are much more likely to be able to do the incentive barometer effectively afterwards. Doesn't mean we're not going to reinforce that teaching in the postoperative phase, but we want to start introducing some of these teaching points in the preoperative phase. Okay, where are we at? We're at, provide emotional and psychological support. Guys, there's so many times that people are afraid when they're coming in for surgery, right? They're afraid of dying. They're afraid of pain. They're afraid of having to be off of work and what that's going to do for their family's finances. There's so many things that they're going to be afraid of, and we're going to be providing emotional support. We're also going to be providing family care, right? Usually we're not just taking care of the patients, we're also taking care of the families. We're going to be answering their questions. We're going to be giving them support as well. I talked a little bit about that fear. Most patients are very fearful coming into surgery. I talked about dying and pain. There's this anesthesia fear that a lot of people have. Anesthesia is medicine that's given by anesthesiologist, a doctor, a provider, and makes you go out, right? A lot of patients are very afraid of not having control. They're afraid of not waking up from going out. They're afraid of what they're going to say or what they might do when they have that kind of medication. And so a lot of that is reaffirming patients. Yeah, go ahead.
Have you ever, like my husband, when he did surgery, his fear is that they're gonna give him anesthesia and he's gonna be paralyzed but awake for the entire surgery.
Yeah, and I know a lot of people have talked about that. There was like a movie that came out a while ago about how somebody was,
There's a movie.
yeah, it was like kind of 15 years ago. We actually have some monitors we can put on people that will monitor brain activity to kind of ensure that somebody is asleep and out. I would say it'd be very rare for somebody to have those medicines and to still be aware. However, there are lots of people who are out, but then can also remember things or hearing things, which is part of why whenever we're taking care of patients, and this is blanket, it doesn't matter if it's surgery or if the patient has dementia and they can't talk or express themselves, anytime we're around somebody, we're going to be appropriate, we're going to be kind and compassionate, and we're going to address the patient, right? When I'm taking care of patients who are contracted and they haven't been verbal and they've been able to talk for years, I still greet them. Hey, Joe, how's it going? It's time to get you turned and moved. I'm going to move this blanket. I'm going to slowly roll you onto your side. Because even though he can't express himself, I don't know what Joe can hear and what he can process. And so I'm still going to be respectful as I would want somebody to be to me or my loved ones. And the same thing for surgery, right? We're still going to be respectful, kind, gentle with people, even when they are out. Okay, next question. What are some interventions for somebody experiencing fear about surgery? So just type in, what would you do? Somebody says, I am terrified. There's crying. What do you do? What do you say? Well, I like the education. What would we educate them about? Yeah, I really like the listening part. Yeah, go ahead.
What sleep cycle are they in under anesthesia? Yeah, I mean,
I don't know if they're in an actual sleep cycle, because with like sleep and REM, I don't know. I think it's a different, I think it's different brain activity.
It's not sleep.
I don't think it's sleep because sleep has like this cycle that you go to as you slowly go out.
Like, no.
They usually don't. No, it's good. It's a good question. People usually don't dream. They usually just wake up and will say, like the young lady who had the miscarriage and went into surgery. She was kind of awake even as she was coming out into the recovery room. And she was like, wait, we're done. I just closed my eyes. Right. It just kind of bypasses your brain activity and kind of shuts you down. I've never heard of people dreaming while having surgery. Usually it's kind of like a blank space that happens.
It's kind of weird.
Yeah, my cousin, she had a brain tumor, and then when she had the surgery, she was awake, and her husband was playing a violin, so she could remember, because
Keep you awake.
yeah, why is it like that?
They want to make sure they didn't mess you up. 'Cause you're waiting for your brain surgery.
I think that's a specialized kind of surgery. I'm not really
Is
sure.
that like they had her skull off and all
Yeah,
that?
they have to remove something, but my cousin, because she loves to, they met when, because they were in the band, she loves violin, so while she was on the operating table, the husband
Was playing the violin.
and she was talking.
Yeah, and there are some surgeries where they might not put somebody totally out. There's a lot of, even like we talked about, I like to use total hips as a example because they're really common. A lot of times people getting a total hip replacement, they'll give them options to still stay awake. A lot of times they might do a spinal or an epidural where they will be just numb from their waist down. They can't feel anything. It's kind of crazy, but then they usually will give them some other medicine to help relax them. Because ortho surgeries for those hips, it's like carpentry in the OR. They're hammering, they're sawing, and usually that's kind of not uncomfortable physically, but it makes them feel uncomfortable when they're like, they can hear the hammering and the like. Yeah. So usually they'll give a medication. A lot of times they'll give Versed or midazolam. That's one of the common medications that patients will get as part of the surgical experience. And that is a forget, don't care medication. And so a lot of times they just won't remember, even if they're awake. I've seen patients who have Versed in lighter doses where they're awake and they're talking to you the whole time. After the procedure, they don't remember anything because that medicine helps them just to relax and not care. Okay, so going back to fears about surgery, I love the idea of listening, like, right, find out why is this patient so nervous? What's going on through their head? That helps us to know what the concern is about. We might be discussing their anxiety and fears. We might want to try using music, imagery, guided imaging. Have I talked to you guys yet about box breathing?
Nope.
Oh, guys, I'm so sorry. I like to bring it out in the first quarter and I haven't brought it yet. So box breathing, I use it myself a lot. I use it with my patients when they're nervous. So imagine a box, and your box can be whatever size or shape. Well, usually you want it equal. And we're gonna inhale and hold, exhale and hold. And the goal is, and a lot of times you use a box, sometimes I'll grab a piece of paper, and sometimes I might just have an alcohol wipe in my pocket, and I'll say, okay, this is a box. With this, we're going to inhale slowly. Maybe we'll have to throw something, and we're gonna hold for that same count. And we're gonna exhale slowly. And then hold for that same count. And then go back to inhale. Can y'all do it together for a moment? Well, let's try for a 4 count. And so since I can participate with you, I'm not gonna say it out loud. I'm just gonna do 1, 2, 3, 4 my hand. All right, so first we're gonna inhale. So inhale. That could be really effective at helping somebody exit an anxiety cycle. A lot of times with patients, when they're really nervous, we breathe really fast, right? We talked last week when we talked about electrolytes and acid-base imbalances. That can just start different effects in our body. We want to have them slow down. If we tell people take a deep breath, if they go like this, that really doesn't do much for them. But if we can get them to do those deep breaths and kind of reset that cycle, that can really help to cause them to calm down, to become more present in the moment, and can help really reduce a lot of anxiety and fear. I know somebody in the answer said, talk to the surgeon or the doctor if somebody's having fear. Absolutely. If somebody doesn't understand what's going on, or maybe they're just like, I don't know if I want to do this, we need to pull in the provider or the surgeon and make sure this is something that we want to go, like, if they're saying, patient's saying no, then we're not going to do it. But they might just need to talk to the doctor and have some questions answered. So pre-admission surgical patient assessment. I want you to notice this word up here, pre-admission. So this is before somebody would come into the hospital or surgery center. If it's elective, right? If we're planning for the surgery to happen, this isn't emergent or urgent. We're going to look at these patients and say, okay, what's their health history? Based on that health history, what are some risk factors that they might have? We're going to start doing education, right? We might start talking about that incentive spirometer, or we're going to talk about, hey, you've got to get up and move after surgery. We want to prevent blood clots. We want you to be moving. We might have some referrals, right? If they need physical therapy, occupational therapy, things like that, we're going to get those started before surgery even happens. They might need some diagnostic testing. You're probably going to need some lab work, especially if they have some of these cardiac, renal, respiratory issues. We're probably going to get a lot of blood work. Usually one is in about a month before surgery, pretty recent. If you are childbearing age, or meaning if you have not passed menopause and you still have a uterus, we're going to get a pregnancy test. People give me pushback all the time. And they're like, I haven't had sex in years. And I feel fortunate, at least I work for a Catholic hospital. And I just say, you know, it's Catholic hospital, immaculate conception, everybody gets one. Like, and so, but that's part of it. If you still have a uterus and you're not 6 months past menopause, they're going to always want to know a pregnancy test. Why is that? Yeah, it could be dangerous for the baby, right? And really, some of these, there was another emergency surgery I saw a few weeks ago where they forgot to get a pregnancy test. But this lady, what did she have? She was another young gal. She had a tonsillectomy and had a copious amount of bleeding. So much so that they had to go in and cauterize or like seal up all the bleeding that was happening back in her tonsils. And they forgot to get a pregnancy test. And I just kind of was walking through and I was like, I don't know who's in trouble now, but that's a big deal. And essentially it was so urgent that the surgeon and the anesthesia provider talked and they said, hey, we have to go right now. And the surgeon said, I don't care. I need to do this. And the anesthesia said, well, I care, but I'm just going to give them medication that's safe for the baby. Right. So that changed the anesthesia provider, what she was going to give to this patient based on keeping that baby more safe if there was a baby. She wasn't pregnant. But you have to always, until you know that they're not pregnant, you kind of have to treat them as if they are. And then advanced directives. What's an advanced directive?
We learned about this. Place when something drastic happens, they know what their wishes are.
Yeah, it's some sort of documentation to say, yeah, if I would stop breathing or my heart would stop beating, what do I want to have? What do I want to happen? So in a facility, like a hospital long-term care, they might have something like a DNR order. What does DNR stand for?
Do not resuscitate.
Good. What is DNI?
Do not intubate.
Do not intubate. At home, they might have a post form. In Washington, those are usually bright green paper forms. And where do they put the pulse forms? On their refrigerator. Because if an emergency care provider comes in, they know to look at the refrigerator and look for a bright green form.
Last night.
Did you?
Yeah, we were on our,
Oh, we
and
are
Clark's
final
questions
group.
right
Oh,
now.
I had chapter 17 and
Good
I
job.
brought it up.
Good job. Yeah. So it's important to know if somebody
Really?
has any of these advanced directives. Also, we're gonna ask, do you have a power of attorney for medical care? Right? A power of attorney or somebody who handles your finances, that's different. If you have a power of attorney for your medical care, that means you've appointed somebody to say, if I can't make a decision, I want somebody, your designated somebody to make that decision for you. That's really helpful. Years ago, when I used to work in critical care, we would have people who they would have to decide whether to stop treatment, right? Like that this patient essentially was brain dead, but who makes this decision if we're gonna stop the ventilator or remove care? And if somebody had a medical power of attorney for medical care, that made that so much easier because we knew exactly who to go to. If that patient didn't, and they had a family who was very divided about what to do, that made that very complicated. Because hopefully that patient has had very specific discussions with that power of attorney for medical care, so they know exactly what their wishes are. If somebody has an advanced directive like a DNR or DNI order, usually they will pause that for surgery. Because think about surgery with anesthesia. Usually we are wiping out your ability to breathe on your own, and oftentimes you have to be intubated during surgery. So if you have a DNR order, that's not gonna fly, right? We can't take you in for surgery saying we have to intubate you if you have an order that says, don't intubate me. So usually in that case, they just have a discussion with the provider. Yes, they want to be a full code during surgery. Once surgery is done and they've recovered, then they can change and go back to whatever their wishes are. Does that make sense? Okay.
I have a question.
Yeah.
Why would someone choose a DNA to be not hospitalized? What, is that someone that's usually like at the end of their?
I mean, it could be. I mean, people have all kinds of wishes. Like, I've had friends who were like 30s, and they're like, nope, I'm a DNR. And I'm like, really? You've got a lot of life ahead. But it's just whatever their wishes are. Sometimes people just don't want to go to the hospital. I think especially if somebody's hospice, something like that.
I wanted to die.
Yeah, they'd rather pass away at home. And so they just don't want to be.
No, my daughter still values, so if you wanna die, live on. They just, they're like, oh, I don't know. Like, why? Okay, but why? And they're like, be good. I'm like, but you don't know what that entails. So yeah, not understand. I'm like, oh, I did want to.
Yeah, definitely education that needs to happen around patients choosing their advanced directives. Oh, I think my battery died.
That's all.
Oh, great. Okay. So some of the teaching, we're going to tell people. So again, this is the pre-admission before they come in. We're going to talk to them about what should they expect? How long are they going to have to be in the hospital? Is it something they can go home the same day? Do they have to stay for a few days? What to wear? It drives me crazy when people come in and they've got their high heels and these clothes with all the buttons. And I'm like, oh my goodness, who didn't tell you to wear slippers and sweats? Because after surgery, you do not want to wear high heels or do all of these, like these men with all their button up shirts. I'm like, you just want something comfortable and cozy to slip on after surgery. We might give the family some discharge instructions as well, and make sure that people after surgery have a responsible adult because they've had surgery, they've had anesthesia, their reflexes aren't the same, they don't make their cognition, they can't make, actually you can't sign legal papers for 24 hours after having anesthesia because you don't have your full faculties. Yeah, and so you have to have a responsible adult that's going to be able to be with you for 24 hours. All right, so in the pre-operative phase, so moving on from pre-admission to pre-operative, what is the role of the nurse in the pre-operative phase? Select all that apply.
Okay.
It lets me pick one.
It only lets you choose one? Oh, man. All right, I probably
Mine has
keyed that
select all
wrong.
that apply, but it doesn't, yeah.
That would be user error. If I don't click the right button, it only lets you choose one. So choose one that you think is right and we'll go over and we'll still show what all the right ones. Okay, so yes, assist with data collection or assessment, right? Develop their plan of care. No, not really. That's going to be probably more of the RN's job. Provide informed consent to the patient. Who gives informed consent?
The surgeon.
The surgeon, yeah. We're going to reinforce patient teaching, provide emotional support, and include families in the preoperative care. So some of the preps, nasal culture. A lot of times we're getting a nasal swab for patients. What are we checking for? MRSA, right? We talked about bacteria and like they like to live in little dark caves. And so we might get a little swab, make sure there's no MRSA there.
Is that
Yeah.
when they give you the iodine in your nostril?
No, so a swab, have you guys done like wound swabs or like culture and sensitivities in lab? So this is just like culturing your nose, seeing if there's any bacteria, MRSA like that. There's also some things that they do in the preoperative area. Nosin, and there's some other products. Essentially, it's chlorhexidine or a cleaner that you swab your nose so that if there's any bacteria that's maybe going to infect you or infect the wound, that gets cleaned out. It's the same purpose that we also do some skin prep. Usually in most surgery departments,
Yeah.
they give you usually Hibiclens or some sort of cleanser to use before surgery. Sometimes they just give you, say, use Dial or an antibacterial. And then when you get to the facility for surgery, they usually have you wipe down with some more chlorhexidine wipes. The purpose of that isn't to remove all the bacteria of your skin, off your skin, but it is to say, hey, if we can remove a lot of the bacteria from skin, nose, wherever it's at, usually they're gonna have less incidence of infection after surgery. Okay, we need to go to the bathroom. We need a bathroom break? Yeah, okay.
Yeah.
Let's take a break and come back at 9.
Okay.
Yeah? Okay.
So I got a question. So if you, like, I'm allergic to iodine,
Mm-hmm.
right? So they start doing little brown sticks.
Oh, yeah, go ahead.
Change them?
Right, so we still got points for our showing, but there wasn't anything that like. Yeah. Like the audience in or like, yeah. Had the. I know this. Right, so you got partial credit for it, but not just the doctor, you know, when we were grading it, we didn't. Grade that as like full. Yeah. I've never used it, but I, is it? I should. I hear you, I know, but the rubric did say like with engagement of the audience. If I just sat up here and read off my PowerPoint, even if I have pictures and other things, if I'm not asking questions or trying to involve you, is that still very engaging? No. Right. And even without experience, there's still, we were hoping for more participation or having people like interact. And I agree, it could have been more. So for the next time, we're gonna have much more clear expectations.
Oh, and then here.
And then that.
Yeah.
That section was worth 25 points.
The way that the room is broken down, that one time. I guess in my head, I think it was half of it. But it didn't have to have.
Right. So I'm just gonna go really quick to the rubric because I'm pretty sure it was 25 points total. So here, it was worth 25 points. So does that make sense that if it wasn't clear how you were having the audience engaged? Yeah, because this whole section was 25 points. And if you didn't engage the audience fully, you got 10 points taken off.
Question about the compare and contrast. So some of them didn't compare, like did we have to, it was either, like if we had hyper. How do I word this? Okay, like, hypernatremia. Or hyponatremia. It didn't really compare and contrast with hypocalcemia because it's, natremia was more like a salt magnesium thing.
Okay.
But I did find a comparison.
That's what
That, I did find a comparison and it showed that people with lung cancer usually have, right?
You don't have to find something that's like comparing might not be just like two patients that are the same. It might just be these people exhibit these symptoms, while these patients exhibit these symptoms.
So I did do that,
Okay.
right? But I also tried to prove like what's the same about them. Like I've noticed that a lot of it.
And you might not have similarities to all of them, so
Yeah.
you might just have to contrast
Just
them.
the one, yeah, I had to contrast them, maybe a couple, but I noticed that every last one of them, vomiting, diarrhea, dehydration was the common factor in everything.
For a lot of them, yeah, which is important to know that those are common threads. Yeah, go ahead. Yes, Amanda and I talked about it and felt that, like reading off the PowerPoints and kind of not engaging the audience, that did detract from the grade overall. We didn't want to take, honestly, we didn't want to take like even more points away. Like technically, we probably could have just moved it down to the 12.5, but we're like, no, we're just gonna do 10 points off. Gotcha. In the overall. Let's meet and talk about it after class. Because I want to make sure that we're able to fully talk about pre and post-op care right now. So is it okay if we table that for right now and then we can bring it back up after class?
Sure.
Yeah, okay. Okay, going back to the mentee. Sorry, guys, it didn't save right where I was at. Yeah. Uh-huh.
Next Monday was Monday after.
Next Monday.
Next Monday.
Mhm.
Okay, next Monday.
Yeah.
What, is it in the lab?
Mhm.
And then do we come back and practice on my end?
Mm-mm.
We don't have to.
Nope. Yeah, so that was a question. I want to make sure everybody hears about the final exam. So the final exam is next week. It's in the lab. Afterwards, you don't have to come back. The week after, there's no med surge. We planned that because we know it's really hard to take finals for all of your classes in 1 week. And so we kind of spread them out so that you don't have to do med surge, foundations, and mental health all at the same time as you're also getting ready for clinicals. So after next week, you're done with med surge. Any questions about that?
How many questions is it? It's like, what it was like.
It'll be a little bit bigger. I haven't finished writing it. Friday, I meant to bring up at the beginning of class. I'm so sorry about all the confusion with your test number 2. Canvas, as I was writing the final for this class, Canvas had a big glitch where everything that I had prepared for the final got overwrote in your test number 2. And it took me about 12 hours to get it all figured out and get the grades changed back and everything into Canvas. So I'm sorry for all of that confusion. But that kind of took me, took up some of my time I was doing for the final. My plan is for it to be about 50 questions. It's going to be varied response. Actually, today I was going to finish up the final and give you guys a blueprint and just tell you these are the chapters that it's covering, and it's going to be pretty equal with those chapters, if that makes sense. Like it'll be 10% of this chapter, something like that, where you guys kind of know exactly what areas to study. I'm going to also keep doing the practice questions that I'll publish for you as you go through. And I'm also going to give you some more resources to keep studying this week. I just haven't got the time to actually keep finishing that yet, but I will be putting that out. I know your time is precious to you and that we only have a week. And so that's my goal today, is to finish getting that prepared for you guys.
So Friday, I think there's something to do with the prepare for your final or something, and that you're gonna pull from there for questions.
Yeah, so you have an assignment for this week of writing your final. So you will be each writing, and please make sure write an individual question. So don't go back through like a PowerPoint and pull one of the questions I already used, but you're to write your own question based on our book. And then I'm gonna pull from everybody's responses, probably a couple questions from questions that people put in that discussion board. Yeah.
When I was looking through the responses, there was something that seemed like they were from before, so are you using questions?
No, students, I've been trying to keep up with that. Students that had put things that were already asked, I had privately messaged them and asked them to do something else as well.
Okay, so it has to be written. Like, we have to come up with questions.
Yeah.
Does that mean on December 4th, we're gonna have class at 8 AM for med-surg?
No,
That is correct.
We have the coffee,
Yes, that's 10 to noon. Will be the hot cocoa bar in here on December 4th.
we don't come here at 8, we come here at 10.
No, I mean, you can come here at 8 if you want to study, but you don't have to come here. I'm not going to give you any more class afterwards.
Okay, thank you.
Yeah, you're welcome. Any other questions? Not so much? Okay.
Number 1.
Oh, thank you. All right, so if you need to log back into the Menti 5943.
I haven't. I never have it. Yeah, that's it. Mine are all natural, so I don't have it.
6220. Oh man, we're gonna run out of time for all the fun things I had planned today. Oh, shoot. Okay, hold on. Gotta go back to where we were. Okay, so let's talk about witnessing a consent. So in a consent form, do I have one on here? I don't think I do. On a consent form, it's gonna have, there's be a sheet of paper and it will say, I give consent or permission to, and then you have to fill in the doctor or provider's name. And then it will say to do whatever that procedure is. And then usually there's several paragraphs underneath there that will say, the doctor has explained to me the risks, the benefits, things like that. Then underneath that, there's a couple of other things it usually asks. One of those things will say, I consent or I decline a blood transfusion. It's really important that we ask patients when they're going into surgery because of anesthesia, they're not able to give us their verbal consent if something were to happen and they would emergently need blood. So that's one of the things we always ask, even if it's like a hangnail removal or something very small where we don't expect much blood loss, we still are going to ask that question of anybody coming in. There are some people with religious beliefs and preferences that do not want to accept any blood products, and we want to honor those people's requests. So that's one of the things we're going to ask them. Now, when we go through a consent with a patient, we're not the ones that are actually saying, do you know the risk for this procedure? And do you know what all of this means? That's not within our scope of practice. That's for the surgeon to go through and explain all of those things. What we're doing is we're saying, okay, I see that you spoke to Dr. So-and-so who's listed here, and you guys talked about this procedure, and they explained the risks and the benefits, all those things with you. And then usually they will have already signed. Sometimes we have them sign the consent. They say, yes, I already talked to the provider. Maybe the provider's there. They will sign. If they have already signed, I always go through and say, hey, is this your signature? We talked about this. This is what you signed there. And then you underneath have a line that says signature of witness, and you will write and sign your name. And you want to always make sure there's a date and a time beside every signature. That's really important to know that when those were actually signed.
Why do you have to witness it? Like, why do you have to actually stand there?
Why do we witness it? Why do we have to witness a consent? Trita.
Certain like choose to say that they were forced into doing it, or basically that they're actually signing it, not being forced to do it.
Yeah, and it's a legal document, and on this legal document, it has to be something that we have to say this is something that this patient is voluntarily agreeing to. So in preparation, we're going to do a checklist. So if you pull out that little assessment piece or the 3 tiled things, this has a lot of the checklist on here. So I think there we go. This has a pre-op checklist on here, but this has some of it as well. So let's just read through this pre-op piece up here. And that's going to be the part on the left side. So there's going to be the assessment, special concern. So what would be a special concern on our assessment? If they're pregnant, yeah, if they have, there's wheezing in their lungs, or there's something abnormal on our assessment or data collection. Maybe their blood pressure is really high. A lot of times when we're stressed, we're going into surgery, we're nervous, our blood pressure might be a little bit higher than normal. And so that would be something I'd want to put on there.
No, on it.
Hmm?
Second, I'm sorry.
The one on the far left.
Okay.
We always want to put their weight, and we're gonna put it in kilos. Do you know why we put their current weight?
So
For
for
the medication.
Yeah, medications. A lot of times people don't know their current weight. They're like, I weigh 102 pounds. You're like, on 1 foot? Like what? Or sometimes patients, I had a guy come in several weeks ago for surgery. He was an older man who had cancer. He said, I weigh 180 pounds. I thought, I weigh 180 pounds. And we got the scale and he was more like 150. He had lost quite a bit of weight with his cancer, but he had weighed himself. And, sometimes we're not aware of what we look like or what's going on. So I'm glad, it's always good to get that current weight because we dose their medication based off of how much they weigh. Last PO, what does that mean?
last time you ate.
Last time you ate. When do we want people to stop eating and drinking before surgery?
12 hours.
Yeah, typically for solid food, we want 12, if not 12, 8 hours before surgery. And we want them to stop drinking clear liquids about 8 hours as well before surgery. So sometimes if somebody has a surgery in the afternoon, they might say, stop eating solid food, at night. And the next day you can have clear liquids up until a certain point. Is coffee a clear liquid?
No.
Actually, it is.
Right?
If you put cream in it, then it is not a clear liquid. Coffee is a clear
Why did I
liquid.
hear that wrong? Like, I'm thinking like water. It's.
Yeah, technically. Last void. Why is it important to know when somebody last went pee?
Make sure they don't have any bladder issues.
No, we need to make sure they go to the bathroom before you go to the operating room, or if not, they need a catheter.
Well, we want to make sure we don't get them into the operating room and they're like, wait, I never peed. And because after surgery, remember opiates make you retain urine, so you're not going to empty your bladder. And so we want to make sure we know if somebody hasn't peed 8 hours after when they last peed, we're going to go and say, okay, it's time. My mom-in-law had surgery a month or two ago, I think, and she had her hip replaced. And after surgery, I was taking care of her in the hospital just as me, daughter-in-law, not nurse hat on. And she was like, I don't need to pee. And I was like, it's been over 8 hours now. I really think you probably do. And she's like, there's no way. And I was like, that's just. She filled up her whole hat, like almost a liter, because she just didn't feel like she needed to pee. But we're checking with our patients because if we don't know when the last time we peed, we don't know how long it's been, because their bladder might be just filling up. And if we're letting them overfill their bladder, they're going to be a higher risk of infection. They're going to have a lot of other issues that happen as well. Okay, blood glucose. There's actually standards out there now. If your BMI is over, I think it's 35, or if you're over, was it not 35? Maybe BMI over 30, age over 35. You're not tested on this, but they want to get everybody blood sugar on that. Because once you start getting older, or if you're overweight, you're at more risk of having altered glucose levels. And if you have altered glucose levels, your body is going to have decreased healing, right? You're going to have some issues with healing after surgery, just like diabetics do. We always want to have an IV on somebody who's going into surgery. So we're going to document that IV. You guys get to learn how to put in IVs later in this program. Very exciting. If there's any labs, EKGs, tests, right? Maybe somebody had a pregnancy test that we're still waiting for the results. We might put something like that on there. Then there's all these little check boxes on here. Is the consent signed? Is the H&P updated? So anytime somebody goes into surgery, they have to have what's called an H&P or history and physical, where the provider has to write down all of their history, all of their physical, and then they have to update it within 24 hours of the surgery, which means the doctor has to actually go in and say, yeah, I looked at you, everything is the same, we're all on the same page. So they actually do like a full HIP2 assessment. I've never seen them do that, but they do go in and have to update and make sure that what they're saying, what the patient's saying, it's all the same. The site needs to be marked. Wherever they're having surgery, the surgeon will actually go in with a skin marker and will usually write their initials or something like that on the area where they're going to do surgery. This is especially important when you have somebody having surgery on an arm or a leg or a certain area. Again, another example, there's a patient who is having a thyroid nodule removed and the doctor signed over here and the patient went, I thought it was over here. And the surgeon went, and he went and he checked the consent form and then he checked the chart to look at the imaging. He goes, you were right. And so we washed off that and we went and marked on the other side. Now, was that not a mistake? It was a mistake, but did it reach the patient? No, it didn't, because we have all of these processes. Because as I was watching him mark, I was going, this consensus for this is saying like a left nodule removal. He's marking over here on the right. We have all of these processes that we follow to keep patients like that we do the correct procedure for them. Yeah.
There is a case that's going on right now. I just read it in the news where a guy went in to have an appendectomy.
Oh yeah, and they removed part of his colon instead.
Right.
Or his bowel.
Like, what, how do you
miss that?
Yeah, it's a good question. I heard that in the news. So if you guys haven't heard, there's a court case happening right now where a patient went in for an appendectomy to get his appendix removed and they took out part of his bowel instead. A lot of people who are not medical are like freaking out. Everybody is kind of freaking out, but think about what is your appendix?
it's a part of your bowel.
It is part of your bowel. I don't know a lot about the case, but my guess is if there was another inflamed part of his bowel that they saw, especially if it's laparoscopic, you know, they maybe aren't seeing the full picture and they might say, oh yeah, this looks what the appendix looked like. I can see where it could happen. I'm not saying that it was correct and that they didn't make a mistake, but I don't think people understand the appendix as part of your small bowel. And so taking out part of your, like, that is the surgery. They're taking out part of your small bowel. Did they take out that specific appendix? No, they messed up. But it's not like they went in and took out his gallbladder by mistake, if that makes sense.
I think it's like they took out something different.
Right. They think it's a different organ instead of just, they took out the wrong section. Yeah,
So did
yeah.
they take out the wrong section and leave it?
That's what it sounds like.
Jesus Christ.
Yeah.
I need to go back to this.
Yeah,
That's the reason.
Oh, that's why?
No, I said it. Left the back, they should.
Now he has to go back and
out.
get another surgery.
I mean, I don't know all the specifics. It's very interesting.
Terrible.
Yep. Yeah. All right, so moving on through some of the consent pieces here. NIV-AO, that's nurse initiated vaccine. I'm not going to test you on that. That's different places have different policies where they want to give you vaccines if you need them. The blood consent or transfusion free is underneath the HMP. That's really important that we know if somebody, are they okay with blood or do they have a transfusion free? A lot of places have what's called transfusion free services where if you have, or you do not want to receive blood products, they'll have people that will come and they'll talk to you about, okay, what are our options? Especially if this is a surgery that's high risk, losing a lot of blood. What are some things we can do in place? Are you okay with maybe donating some of your own blood to store, you know, ahead of time, where you can then have a transfusion of your own blood? We want to work with people's beliefs and respect those, but also do what we can to keep them safe with surgery. Anesthesia consent sign. Some places have separate consents for the anesthesia. Some places have it part of the surgical consent. And then there's also beta blocker taken. There's studies that if patients are on a beta blocker, what's an example of a beta blocker? Metoprolol. Yeah, that's a really common beta blocker. What do beta blockers do to your heart?
They slow it down.
They slow it down and then they increase the contraction force. When patients who are on beta blockers take them before surgery, they do better. If they skip their dose that morning, they have worse outcomes. So if somebody is on a beta blocker, we always make sure that we tell them, take it before surgery. You forgot, we'll give it to you. You're good. Because we know that they're going to have better outcomes if they have that beta blocker. Then we have special attention underneath here. Family. You always want to write down who's here for you. Are they waiting here? What's your contact number? If your hospital has a paging system, we're going to give them a pager. And then at the very bottom, let's go down, belongings with the patient. This is really important because whenever we have somebody who comes in with something, we want to make sure they leave with it. And a lot of times glasses, hearing aids, dentures, those are the things that, first of all, can be very expensive and very easy to lose. And these are things that we don't want to take off early, right? A lot of times we're going to remove most places are going to remove jewelry. You don't want any metal on somebody. Why don't we want metal on them?
Or MRI.
It could be bacteria threshold. Usually what they say is when they might use cautery. It's an electrical impulse to stop bleeding. That can have an electrical arc and it might burn somebody if it arcs to the metal and whatever they're wearing, and then your skin can burn. Sometimes patients, if we just like, this person's like, I've had my wedding ring on for 50 years, I've taken it off, I haven't taken it off before, it won't come off. A lot of times we'll just say, hey, there's a risk, you could possibly get a burn, it's very likely, we'll keep it on. But usually, especially if somebody's had like abdominal surgery, we know we might use cautery and we've got a belly button ring, we need to get that off because we know they're a lot higher risk of having like a burn. We're gonna take all their jewelry off. But patients with glasses, hearing aids, we need them to have those on because we need to assess them, right? We're going to ask them to do things and so we want to have them right until they fall asleep. And then when they fall asleep, then usually we'll take those glasses off, we'll hold them for them, and then we'll give them to the next phase of care. And we're going to write that here because we want to make sure that we know, hey, I'm sending this patient with their glasses, with their contacts, whatever it is. So the next nurse, if you're taking over, you can say, oh yeah, they have these, and I'm going to make sure I bring those with the patient as well. Okay, so we're going to be verifying their data, the surgical site. We talked about all of this. Antibiotics, most standard care, like we talked about beta blockers, right? If they are on a beta blocker, we want them to have that in 24 hours. We also want them to have an antibiotic within 1 hour of the incision. It used to be nursing staff would give that. And then we discovered if there was any kind of delay that happened, maybe the surgery in front went long or something like that, then we would be like that patient would pass that hour mark and then anesthesia would have to go ahead and give another dose of antibiotic. So now anesthesia just gives that antibiotic. When the patient goes back, they're given their anesthetic, they fall asleep or whatever they're doing, then they give the antibiotic. And that's one thing before the procedure starts. A nurse will always do the timeout, where they will stop. And in that timeout, everybody stops. It doesn't matter if you are the scrub tech, the doctor, anybody, the rep in the room. Everybody stops and you all make sure that we're all on the same page. And they're going to make sure this is the right patient. And we're not just going to look at the chart and the consent. We're also going to have somebody looking at the actual band, right? Because that patient usually is going to be already asleep. They can't tell us that that's them. We're going to make sure it's the right procedure. We're going to make sure it's the right side, right? That would be another point where we would stop and say, wait, is that the right side that we're biopsying for that thyroid we're taking out? They're going to make sure that everything, all the consents are done, any supplies that we need before we start, are we completely ready and all on the same page? I've had to do this before, lots. And sometimes there's going to be surgeons or other people who are like, and I just say, oh, I'll wait to do the timeout until you're ready. And then they're like, oh gosh, but it's for that patient's safety. We can't have people making side conversations. Timeout is for the whole team to be involved. And so if you are ever responsible for doing the timeout, please know that sometimes providers, anesthesiologists, other people want to maybe give some pushback and say, come on, let's go. But that's a safety issue. And so that's our responsibility to kind of stand our ground and say, no, this is for the patient's safety, to make sure that's kind of the last stop before you have surgery, to make sure we're doing the right thing. And then pre-warming. Surgery suites are really cold. They're cold on purpose to help prevent bacteria and infection and things like that. But our patients get really cold. So we usually try to warm them up a little bit before surgery. And then after surgery, we might be warming them up. That's going to be a variety of things. Either warm blankets. Sometimes they'll have like little gowns or blankets that have like warm air put through. But we want to try to keep them at a normal temperature. We're not trying to keep them above a normal temperature, but usually patients come out of the operating room a little bit chilly. So we want to keep them or kind of brace them back up to a normal temperature. Oh, this is what a normal, what an operating room might look like.
Might. That's
10 years
mighty
ago.
empty.
It's a little old, yeah. So then let's go arrival to surgery. So that's going to be our middle section, right? Now we're the operating room nurse. We might have the patient tell them, hey, this is what you're going to expect. We might help position them. There's going to be a lot of safety. We go back and look, this bed is really small. There's no rails. There's not a lot on there. So there's actually, usually you have some arm boards you put underneath to help position the patient. They have a bunch of seat belts and straps that they put on to make sure that patient doesn't go anywhere or move anywhere. So there's a lot of safety issues or safety pieces that go into positioning the patient. After the patient is induced or given anesthesia, they might put some different lines and tubes in place. They might intubate them, put them a tube in for breathing. They might put in a central line if they need one of those. A skin prep, that's going to be cleaning off the specific area. All staff in the operating room are going to have gowns, special gowns, masks, a hat. Depending on what your role is, you might have to scrub in. A lot of times LPNs operate as a scrub nurse. And so if I'm just the nurse that's circulating, I'm kind of walking through the OR, I might be going and getting supplies and delivering them, doing timeout. But the scrub nurse is actually scrubbed in. So that's where, you know, like in movies, you see them like washing their hands and they're scrubbing and they're doing all that. It's actually like, that's what you have to do. You scrub in, you get sterile. Somebody has to help you with getting your gloves on and everything. And you assist the doctor in helping him. That's one of the roles LPNs can have. You maintain that all of your instruments are on a sterile field. Have you guys done sterile field, sterile gloving? It's really fun. I was just telling somebody, I can't remember, about how I've been teaching clinicals at one of our acute care sites this last term. And I had the opportunity to send almost everybody through surgery. And that was one of the big things that I told them, like we'd go get them their special scrubs they had to wear. And then it was like, okay, you remember sterile field, right? Remember from like usually Foley hats and sterile gloving. If the sterile field is open, we stay back and we stand like this because we just don't want to touch anything in that sterile field. You really want to maintain, you know, there's nothing worse than somebody going in and knocking into a sterile field and then they have to like do everything. But you're maintaining it if that's your role. You're watching to make sure that nothing is getting in your sterile field and contaminating it, and you're assisting the surgeon. Anesthesia, there's lots of different ways you can have anesthesia. You can have it in your IV. You can inhale it through different gases. There is a complication called malignant hyperthermia. You don't need to know a lot about it other than it's a genetic condition that causes issues in your muscles. You overheat, you have lots of issues. You just need to know that it's a complication of anesthesia. Local anesthesia is, think about numbing medicine. Anybody had dental work done and they had to inject lidocaine or something in your mouth? That's local anesthesia. So they do that too, to like maybe they're gonna, actually wherever they do surgery, if it's your hand, your arm, your leg, your back, they're going to numb up a lot of that area, and that's called local anesthesia. That's usually given by the surgeon, not the anesthesiologist. Here's a picture of endotracheal tube. You can see how people, when they're lying back, a lot of times their tongue can kind of press back, especially if they're really relaxed, and it can obstruct their breathing. And so you have this tube that goes in through the trachea. So this is the esophagus here, into the trachea, and it has a little balloon that will inflate so that they manage all the air that comes in and out through this tube up here. Have you guys done airways in foundations yet? Okay. You'll get to play with, not play with, you'll get to practice care, I believe, at endotracheal tubes as well as tracheostomies. Tracheostomies are fairly similar to endotracheal tubes, but they're a little bit more permanent. And they usually they bypass the oral route and they are made through an incision here that goes right into the trachea. So you'll learn more about that later. So again, malignant hyperthermia, it's a rare hereditary concern. In preoperative care, you always ask somebody, have you ever had problems with anesthesia? Has anybody in your family ever had problems with anesthesia? If they have, we want to find out a little bit more in case they have. Again, you don't have to know a lot about this. Here's a nice little picture of some spinal anesthesia. Sometimes anesthesiologists will give, they'll like numb up lower parts of your body.
That's more like.
After, yeah. So this is once a patient's in the operating room, this is more of what it might look like. You'll have, you can see, this is probably the surgeon here. Here's probably the scrub tech, another tech. Here else, there you can tell because they have the big sterile gloves on. This is anesthesia. This is pretty typical. Anesthesia is just at the head of the bed. They usually don't see anything what's going on with the patient. They're just more cared with breathing and then whatever the numbers are going with blood pressure, oxygen sats, all of that. PACU recovery. All right, so that's our very far right side of the page that we're looking at. So when somebody comes into PACU, what do I have to here? Okay. Well, what are the first things you think we need to do with somebody when they
Vital
roll
signs.
in? Vital signs, yeah. What specifically? Respirations and oxygen saturation. Those are the two biggest things because we know where you've depressed the respiratory system. We've been breathing for them. They're usually extubated or that tube is usually pulled out before they come to recovery, but sometimes they still have it in because they can't maintain their airway on their own. Sometimes you come in with an oral airway. Are they still teaching you guys that in BLS? Like CPR class, like oral airways, not so much, okay. So sometimes you might have an oral airway that just kind of holds your tongue and jaw in place. Sometimes there's nasal airways that can go in through your nose and just kind of provide an open space.
It's got that tube, it's about like yay long, kind of curved.
Mhm,
They
mhm.
jam it up in there. Yeah, that's.
A lot of military people like to use the
Yeah, that's what
nasal
I like that
airways.
too. So when we learn how to secure an airway.
Yeah, so nasal airways are great. And usually
like hell.
when I have anesthesiologists that I work with that use nasal airways, they're usually military folk. But they're great. They work really well because sometimes the oral airways can be a little bit tricky and the nasal ones, they go
We
back
actually
there, they're great.
practice on each other. Yeah, you stick it to,
Mhm.
you practice in the field. It's a
Mhm.
course that the military offers, combat lifesaver course. And they teach you, the medic comes in and he's like, push the nose up and jam that sucker in there. That's pretty much how it goes.
More or less. All right, so we're gonna get vital signs on our patient. Neurostatus, are they waking up? Patient should be waking up once they get to recovery. They might not be able to keep up and keep a, conversation, but if I'm like, hey, usually they should be able to open their eyes. If they aren't, we need to talk with anesthesia and we should see a progression of them slowly waking up. Cardio, we're gonna have them on a heart monitor and we're gonna be looking at what their rhythms are. We're gonna talk more about this next term. Cardio is super fun. I'm really excited about it. But you might see some abnormal beats, especially with low oxygen levels. So when I start seeing somebody start throwing some weird beats, I'm like, you probably should put some more oxygen on them. They might have been borderline. I'm like, okay, their body's starting to get affected by it. Their pulmonary status. You see this thing down here says DTV. What does that mean?
No, that's wrong. DVT.
Due to void.
Due to void.
So how we wrote here on this first one, when did they last meet? Now, we're gonna count 8 hours from that, and that's gonna be their due to void. If they haven't voided or peed by then, that's when we're like, okay, it's time. You don't feel like it, it's still time. They still can't pee, we'll bladder scan. They still can't pee, we'll contact the provider, because we probably need to do a straight cath or something to help them to pee. Okay, what else is on here? By the time they leave, we're gonna put some other information on here. When they're ready to exit the PACU, we're gonna say, what does their dressing look like? What about their activity level? Sometimes somebody, especially like surgeries on the legs and feet, the surgeon might say, hey, I just want partial weight bearing on this foot. Red socks, they used to be.
Yellow socks are what everybody gets, it's just like a general.
So what
fabric.
about
But
red socks?
Red socks
like
are what they used to have before yellow socks.
Cause they're blue sock
Wait.
now, they're.
Red sock, what? In
Red
my
socks-
opinion, red's more than yellow, so like yellow's just like, oh, they're the kids fall.
The Franciscan system for their high fall risk socks, so non-grid socks, that used to be red was the color for anybody that was a high fall risk for their socks. I don't know how many years ago they changed it to be yellow socks was the color for high fall risk. And so this paper just has never been updated.
Yellow socks.
It might, I mean,
I'm gonna start asking for it.
no, they don't have them anymore. They don't have, the red socks was like 15 years ago.
I've seen them.
At Franciscan?
I could scan.
Yeah, different
But there's
facilities
the-
have different
more
coding.
yellow. There's normally yellow and that taupe color.
All right, I'm gonna keep us back on track. You're gonna talk about what medications you gave. Two of my 4 patients this weekend woke up saying, please don't give me fentanyl. There is such a big
Fear.
opioid, issue, where people are dying of fentanyl overdose on the streets, but people are afraid to get fentanyl. We've given fentanyl in recovery room and other, lots of other places and facilities for decades. But now that it's on the streets and people are getting it in these very intense doses, they're actually, they're misusing it. And what I try to, I always want to honor my patients' wishes. They don't want fentanyl. I will try my best not to give them fentanyl. It's a very effective drug. And I really like fentanyl because it's very quick acting. It has a very quick onset of action. And it also has a pretty quick half-life, meaning it's going to be out of their system fairly quickly. I like that because it gives me more control over my patients. Like if somebody's pretty sleepy and they maybe have a little bit of a depressed respiratory system, they're not breathing as well as I want them to, but they're also saying they have a lot of pain. It's very intense. I can give them some fentanyl and I know that it's going to help them. I'm going to see what it does pretty quickly. But if it starts to knock out their respiratory system a little bit more, I know that's not going to be in their system. Whereas if I give them morphine or Dilaudid, some of our other opiates that we have in IV form, they last a lot longer. And so if I give them that medicine and they're not breathing a lot longer, I'm going to be sitting there for a while, either holding their jaw up so they can breathe or, bagging them to make them breathe, which I don't have time for. So I like to give fentanyl.
Like, what kids need to throw up,
Yeah.
and after surgery, throwing up sucks.
Yes.
You have a pen for however many hours, and you're just throwing up like
Dry
stomach
heaving?
acid.
Yeah.
It's terrible. So I'm like, I don't want that. Like,
And if you have an allergy or you experience,
give it to me anyway.
sorry.
I'm like, I know, I'm wait. Growing up is makes it worse. So then they have to do a little like patch thing.
Mhm. Mhm.
Like dying for longer than I should.
Yes. So scopolamine was one of the medicines I wanted to talk about today. So a lot of times people will have nausea after anesthesia or from the medication. And so it's called scopolamine. Oh gosh, let's see if I can spell this right.
That's that ondansetron stuff.
Nope.
It's a little like patch that goes behind your.
I think I'm spelling that correctly. It's a small little patch. It goes on the skin. It's slowly absorbed and it helps with nausea. A lot of times patients who have a lot of nausea after surgery, we will put this on because it lasts for 3 days. It helps them with that nausea, it helps to kind of dry up some of the secretions. We also tell people because of what it does, the adrenergic effect, it can, if you kind of play with it and then you touch your eyes, it can cause blurred vision. It won't keep your vision blurred, but we always let people know that is a possible effect. So please don't touch your eyes after you play with the patch. It's really effective, especially if somebody's nauseous at home. They can't have IV medicine, right? Usually they have to take an oral pill, a disintegrating tablet under the tongue. And so the scopolamine is really effective because then they don't have to put anything else in their mouth. It's just on them for 3 days. They don't have to do anything for it. It's just there. And even if they forget to take it off at 3 days, it's just like having a sticker on your neck. It's not really going to do anything bad for them. So it's very effective nausea medicine. So to leave PACU and to go to the discharge area, you want to make sure somebody's vital signs are stable. You want their oxygen over 90%. Typically, places might have a little bit higher, but because we're depressing their respiratory system, they kind of allow for a little bit lower oxygen levels. They want them to be awake, baseline level of consciousness, the respiratory system, not depressed, they're breathing, or meaning they're breathing on their own, and bleeding controlled. We're gonna skip over that because we don't have a lot of time. Boo, boo, boo. Sorry, I'm skipping over this because we are running low on time. All right, so post-operative respiratory complications. What are we going to do to help prevent those complications? Choose all that apply. Man, sorry guys, that's me for not clicking the right button. So choose at least one that would be appropriate. Oh. There, okay. So deep breathing and coughing, yes. Before we had an incentive spirometer, that's what we had people do. We had them take a deep breath and then cough. And that's the kind of cough you want people to do. Sometimes they'll go, hey. I'm like, okay, did that actually clear anything in their lungs? No, I want them to do a big, deep breath and a big cough to clear out and open up those lungs. Incentive spirometry is really effective. We want them to do that. Early ambulation, what does that do?
It's up going again. It's never, everything in our body moving.
Can prevent pneumonia because they're gonna be expanding their lungs. It's hopefully gonna prevent blood clots because they're gonna have their circulatory system pumping through. Blood isn't gonna be kind of a stasis, in stasis as it was. Leg exercises, yes, when they're in bed, especially if they can't get up out of bed on their own, we're gonna teach them do things like gas pedals. So their feet, my arms or my feet, back and forth, gas pedal pump. Maybe just shifting up and down, little things just to keep their body moving. Those little things aren't as effective as getting up and walking, but at least they're going to be helping move that blood through and keep blood clots from forming. There's a stapled incision. You guys probably will be taking, if you're working in a post area, eventually be taking out staples. You'll be removing them. Healing phases, we're going to talk too much about this. Okay, so dehiscence and evisceration. This is abdominal wounds. So a dehiscence is when the suture line or whatever is holding it together has pulled apart. Evisceration is after dehiscence, and when you have abdominal, I don't say ingredients, that's not the right word, abdominal contents spilling out from that wound. I like to think of evisceration as escape, like the abdominal contents are trying to escape. That's how I remember the E for evisceration, and that's when the abdominal, usually bowel, is coming out. So that's always a complication of somebody that has a large bowel issue. Again, it's very uncommon, but what do? We put somebody in low Fowler's. So we want to kind of have them on their back, knees flexed. We want to kind of create like a little cavity for that to kind of stay in. We get sterile towels and we put some sterile saline on them and put that on there. If we have warm saline, that's better. And then you're going to be calling for help, right? You're going to call the surgeon because they're going to need to go immediately back to the operating room to put everything back together. So if somebody's going to go home the same day, what do they have to have? A little bit different than just leaving the recovery room. Their vital signs need to be stable, no bleeding, no nausea and vomiting. They might have some nausea just because some people just have nausea after anesthesia, but we do want to make sure that they're not constantly vomiting. They're able to keep some fluids down. We want them to be able to have voided if they needed to. Some patients will say, hey, you need to pee by 4 o'clock this evening. If you can't, then you need to call your doctor. Some patients, especially if they had a urologic procedure or a bowel procedure, we might say, hey, we actually need you to void. We need you to pee before you go home because we want to make sure there's not a complication or something that's happened. We want to make sure their pain's controlled. a lot of times, in the preoperative area, we're gonna ask patients about their pain goal. A lot of times that's not necessarily, so we stick to this pain goal, but it's more to start that conversation of, when you have surgery, you're gonna hurt. Sometimes when I ask people, what would your pain goal be after surgery? And they'll say, well, I want it to be a 0. Okay, can't quite do that with keeping you breathing. So where can you live on a scale of maybe having some discomfort that you could go home? And you'd be surprised that some people really think, they're like, no, I'm gonna get it fixed, I shouldn't hurt. But surgery hurts a paper cut hurts, right? An actual incision and, moving things inside you really can hurt. We want to have them discharged to a responsible adult as well. All right, which do we include in our discharge teaching? Select all that apply. Did I select all, or can you only choose one?
Only one.
All right, so what complications to report to the healthcare provider? Yep. CPR training for the family? No. Instructions in writing? Yes. We're going to verbalize the instructions, but we're always going to give them to them in writing. And I really encourage everybody to highlight the important areas that you want them to know, because most discharge packets that we print off have a lot of information that's not really important for patients to know on there. Instructions signed by the patient or family? Yes. When we give our discharge teaching and we give the instructions, we actually have them sign a paper that we keep to say that, yes, I've received these instructions. That's our document kind of saying that, yes, that's them affirming they did receive them. And then we also want to explain what medications they're taking so that they know, what is this for? Why should I take it? And how should I take it? We're also going to teach them about wound care, what kind of dressings they might have, how to take care of it. Most patients, we want them to rest for 24 to 48 hours, sometimes more, depending on what kind of surgery that they had. While they are taking pain medicine, or actually for 24 hours after anesthesia, there's no operating machinery, signing legal documents, anything like that. But while somebody is taking an opioid medication, like pain pills at home, they are not able to drive. That's considered impaired driving in the state of Washington. So I always make sure my patients know, hey, you have maybe Percocet or Vicodin or oxycodone. You can take that. It's ordered by the doctor, but you cannot drive while you're taking that medication. We also want to make sure that we give them any prescriptions that they've had ordered. There's somebody, again, a while back giving discharge instructions. Oh, that was it. Okay. I have a few minutes. I would really love to go over the case study that we did for surgery. So this one, do any of you guys remember doing this?
Yes.
Did this feel easier or harder than the one we did before?
For me,
I felt like it was
Easier than the first.
Easier, yeah. That first one maybe was not the best one to do. So I want to just go through this together with you guys, because I think it kind of pulls together what we talked about today and exposes you to some new types of questions. All right, so this is question 1 of 6. Remember, on the NCLEX, you are going to get 3 case studies that are like this. Each case study has 6 questions on it, okay? So, am I the first person telling you guys that?
no.
No, okay, I was gonna say, that's part of just, I want you guys to get used to this whole case study piece, because you're gonna see it on your NCLEX. All right, so the nurse is caring for a 47-year-old male on the post-surgical unit the 2nd day after an appendectomy. What's an appendectomy?
That is appendix removed.
Appendix removed. Ectomy is removal. So post-operative day 2, 0800 note. Vital signs are stable, breath sounds clear. Incision intact. Should make it bigger. There we go. Client reports pain 4 out of 10 at surgical site, declines pain medication. And then at 1400, vital signs as noted, so we can go see down here. Client is short of breath and having difficulty breathing and coughing. Requesting pain medication. Breath sounds on left are diminished compared to previous assessment. Client and families are requesting an update from the physician. So we can see what the vital signs are on here. And it's asking us which findings require immediate follow-up. Select all that apply. So what do you guys think on which things should be requiring immediate follow-up, excuse me. I heard diminished respirations.
Blood pressure is kind of high. I got a little confused with this because the blood pressure is kind of high, but it could be from the pain that he's experiencing. The pulse oximeter reading.
Yeah, and I heard in the back there, that's the piece, it doesn't require immediate follow-up. The blood pressure is a little bit high, but does that require immediate follow-up?
No.
I don't really think so. Medication 5 out of 10?
No.
No. Because it's contributing to their heart
Yeah, but
rate
he
and
can't
respiration.
breathe, so most pain medications are, it depends if he's on an opioid or not. So I don't want it to.
It could be a normal finding. We're expecting somebody to have pain after surgery.
Right.
So having some pain, I would say I don't think this requires immediate follow-up. What about feeling short of breath?
Yes. That's pulse ox.
What about pulse ox of 92?
Yes.
Yeah, especially if we go back up here and look at the trend, they were 97% earlier this morning, then 96, now 92. I would say, yeah, that's definitely not their normal, so that requires. And then what about family asking for an update from the physician? Is that an immediate thing?
No.
I don't think so. Oh, there it is. All those things were correct. Good job, by the way. So our next question. Do we need to read through all the notes again? No, they're the same ones, so we don't need to read them again unless we need to reference back. The nurse considers conditions that can cause post-operative respiratory distress. For each finding, click to indicate if the finding is consistent with pneumonia, post-operative atelectasis, pulmonary embolism, or fluid overload. Each finding may support more than one type of condition, but you have to have at least one response. So diminished breath sounds. Could it be pneumonia?
Yes.
Post-operative atelectasis, pulmonary embolism,
Yeah.
Yeah.
No, because it's really sudden.
it's usually not, we wouldn't say the diminished breath sounds, it would be absent breath sounds with a PE. Oh, no, fluid overload.
Yes.
No.
Not usually, you'd have some adventitious blood sound or lung sounds.
Okay. So that would be
Um,
freckles and all that stuff.
Yeah, and actually, just to go back, pneumonia, you wouldn't have it either, because typically you would have those advantageous lung sounds.
Okay.
Wheezing, rhonchi, something like that. It wouldn't necessarily be diminished. Okay, low-grade fever. Would we have that for pneumonia?
Yes.
Post-operative atelectasis?
Sure.
Yeah. There's no.
It's not a collapsed lung, but it's collapsing. It's the specific alveoli. And yes, you do have fever with post-operative atelectasis. Oh. Pulmonary embolism,
No.
fluid overload, repressed coughing. You have that with pneumonia?
What's repressed? What does that mean? Repressed cough. No coughing? No.
Where you're not wanting to cough.
Oh, no. You're not.
Yeah, so usually you cough more with pneumonia. Post-operative atelectasis, yes. The pulmonary embolism,
No.
fluid overload, decreased pulse oximeter.
Yeah.
Yes, with pneumonia.
Yeah.
Yes, pulmonary embolism. Fluid overload. Yeah, absolutely. What about a stable blood pressure? Do you have that with pneumonia?
Yes.
Yeah, it's not like an unstable blood pressure isn't an indication of pneumonia. What about postoperative atelectasis? Yeah, you usually have a stable blood pressure. Do you have a stable blood pressure when you have a pulmonary embolism?
No.
No, usually what happens? Usually your blood pressure will go up. What about fluid overload? When you're, who is our fluid overload group? What happens when you have fluid overload with your blood pressure? It goes up. Yeah, it's not stable. All right, so drag the most appropriate word or phrase to choose or to fill in the blank. The nurse, the nurse should recognize the client's most likely experiencing post-operative atelectasis. Atelectasis. That's when our patients, they're not breathing as well as they should. Those alveoli are kind of collapsing in, not the whole lung, just a specific alveoli. And so we want them to expand and reopen those back up. So we have another little note here, 415, provider notified of changes, started on 2 liters of oxygen, portable x-ray obtained. We have a new set of vital signs. Looks like they started them on 2 liters and now they're up to 93%. Thank you. So then we say they're diagnosed with mild atelectasis. Good job for choosing that. For each order, click whether the intervention is indicated or not indicated. So do we want to give pain medicine?
Yes.
Yes. Do we want to give a fluid bolus?
No.
Not indicated. Have them use incentive spirometer?
Yes.
Yes. Place in the supine position?
No.
No. What do we want them to be? Usually Fowlers or semi-Fowlers, we want them more upright to help with their lung expansion. Request a CBC lab stat.
No.
Not really, because if it's atelectasis, it's not an infection. They might want a CBC, just to maybe determine, like, to give more information, to make sure it's not a pneumonia, but it wouldn't necessarily be stat. Okay, no more notes. Okay, we got diagnostic. The chest x-ray shows mild atelectasis. We had orders for 2 to 4 liters per nasal cannula to get the oxygen levels over 95%. We got an order for morphine and to use the incentive spirometer. So we're developing a teaching plan. What should we teach the client? Do we want them to get out of bed and ambulate?
Yes.
Yes, we do. Sit upright when using incentive spirometer? Absolutely. Do we want them to take deep breaths?
Yes.
Yes. Limit fluid intake?
No.
Avoid use of pain medication right before incentive spirometer?
No.
No. How to splint during coughing?
Yes.
Yeah. Okay, last question. Okay, 1430, medicated with morphine, teaching provided on spirometer. Client gave return demonstration, breath sounds diminished on left, coughing after incentive spirometer use. Another set of vital signs. Now they are 97% of the 2 liters. All right. The nurse recesses the client at 1500. For each finding, click if it indicates the status has improved, declined, or unchanged. So for 97% on 2 liters, is that improved, declined, or improved? Breath sounds diminished on the left. Unchanged. It's the same as it was. Temperature. Well, where did it go? It went up. Yes, it actually is declined, right? It's not as good as we want it to be. Coughing after incentive spirometer use.
Improved.
Yeah, it's actually improved. We want them to be coughing and moving their lungs. Okay, and so good job. Those were the correct answers. I'll publish the correct answers on the resources if you want to go back through and see those. If you are finished, or actually, I'm so sorry to be over on time today. Please upload your KWL to the assignment. Remember I didn't say it on the announcements. I accidentally wrote the extra credit assignment for surgery. I thought it was clinical judgment. It's actually personalized learning is what it's called. You just have 2 assignments in FA Davis. The quizzing is one that's usual. The other one is the personalized learning. That's the extra credit assignment. So if you did the personalized learning, just upload that one to that assignment. That's the extra credit portion. And make sure you make your replies to all the group projects by tonight. That's when all those replies are due. Please make sure in your replies that you're comparing and or contrasting to the other groups, not just telling them they did a good job or what you learned. It's the actual compare and contrast that's required. All right, thank you guys, and thank you online.